Welcome to the deep dive. Today we're tackling a topic that's incredibly common but often stays hidden. We're talking about female urinary incontinence, or UI.
It really does affect so many people.
Exactly. It's a huge issue, can really impact life quality, but far too many women feel they have to deal with it alone, maybe thinking it's just inevitable.
That's right. A normal part of aging or childbirth, which isn't necessarily true.
So we've gathered the established clinical guidelines. Think of it as a roadmap. We want to help you understand how UI is diagnosed and, really importantly, how it's treated effectively.
And the scale of this, well, is pretty staggering when you look at the data. Depending on how exactly you define it, UI affects anywhere from, say, a quarter to maybe even over half of all adult women.
Wow, that's enormous.
It is. And it's not just a minor inconvenience. We're talking about a serious hit to quality of life. It can erode self-confidence, make women shy away from social events.
Avoid exercise, things like that.
Absolutely. And it definitely causes issues with intimacy, sexual function. There's often this layer of shame associated with it.
That normalization, that acceptance of distress, that's really what we want to challenge today. Our mission here is to break that silence by, well, unpacking the clinical pathway. We're going to focus mainly on the two big types because telling them apart is really the crucial first step towards getting the right help. That's stress incontinence, SUI, and urgency incontinence, UUI.
Understanding the difference is absolutely key. Should we start with stress urinary incontinence, SUI?
Yeah, let's do that. If I'm following the sources, SUI is more of a mechanical issue, right? A sort of plumbing problem.
That's a great way to put it. Yes,
Yeah.
SUI is involuntary leakage that happens when there's a sudden increase in pressure on the bladder. So, think coughing, sneezing, laughing.
Jumping, running, lifting something heavy.
Exactly, those kinds of actions. The pelvic floor muscles and the sphincter, they just can't quite maintain the seal under that sudden load. And, interestingly, it tends to be the most common type in women under 50.
Okay, so that's SUI. Then there's UUI, urgency urinary incontinence. That sounds different, more about the bladder muscle itself acting up.
Spot on. With UUI, the leakage comes after, or sometimes during, a sudden, really intense, and basically uncontrollable urge to urinate. It's that gotta-go NW feeling that overwhelms you.
Right.
And just a quick note on terminology. The sources we looked at are clear that the older term urge incontinence is now officially urgency incontinence, so UUI.
Good to know. And if someone has symptoms of both?
That's called mixed UI. You get features of both SUI and UUI.
Okay, let's unpack this hidden aspect you mentioned. Given those prevalence numbers, a quarter to over half of women affected, why is there such a big gap? Why do so few women actually seek help?
It really is the tragedy of silence we touched on. The data suggests only about a third, maybe 33% of women who have symptoms actually talk to a doctor or nurse about it.
Only a third. Why?
Well, the reasons they give are quite revealing and, frankly, a bit heartbreaking. Almost half, something like 47%, said they just thought the symptoms were normal, an expected part of getting older.
Just accepting it.
Yes. And another 57% said they kind of found their own ways to cope, maybe using pads, restricting fluids, or just avoiding activities they know might trigger it.
Okay.
But the biggest group, almost three-quarters, 73%, simply felt their problem wasn't severe enough to bother a doctor with.
Wow, 73% feeling it's not bad enough. That really shows how much women might be minimizing their own discomfort, doesn't it? They're normalizing something that, as you said, is often treatable.
It really speaks volumes about maybe a lack of open conversation around pelvic health in general.
Right.
But look, the positive side is that when women do seek help, the diagnostic process itself is often surprisingly straightforward and effective.
And it starts really simply, doesn't it? Just by talking and listening.
It absolutely does. The patient history, the anamnesis, is incredibly powerful. Just by carefully listening to a woman describe when the leakage happens, you can usually figure out if it's SUI or UUI pretty reliably.
So the pattern of leakage tells the story.
Exactly. The predictive value, based just on that description, is quite high. For SUI, it's around 70% accurate, and for UUI, it's about 73%.
So talking about it isn't just therapeutic, it's actually a core diagnostic tool. What comes next, then, to kind of formally track those patterns?
The next really key tool recommended consistently in the guidelines, especially the European ones we looked at, is the voiding diary.
Okay. A diary. What does that involve?
It's usually kept for about 3 days. Some of the Dutch sources refer to it as a Michty dog book.
Right, a 3-day snapshot. What kind of things would you track in it?
Well, basically everything related to fluids. How much you drink, when you drink it, when you go to the toilet, how much you void, roughly estimated, of course.
Mm.
And crucially, any episodes of leakage. When did it happen? Roughly how much? And what was the trigger? Was it a cough or a sneeze suggesting SUI? Or was it preceded by that sudden, intense urge suggesting UUI?
Makes sense. And I suppose this diary isn't just for the initial diagnosis.
No, that's the other great thing about it. It sets a baseline. Then, later on, after starting treatment, you can use another diary to objectively see if things are improving. It helps track progress.
That's clever. Okay, so since the diagnosis hinges so much on understanding those triggers, let's use that knowledge. Let's pivot specifically to SUI treatment stress incontinence, the pressure-related type. What's the first line of defense according to the guidelines?
For SUI, the initial approach is generally conservative, non-invasive. The two main first choices are pelvic floor muscle training, PFMT, or using a device called a pessary.
Okay, PFMT. Most people have probably heard of Kegel exercises. Is PFMT basically a more structured version of that?
It is, yes. It's much more specific than just sort of casual squeezing. The real goal of PFMT is to improve the strength, the coordination, and crucially, the timing of those pelvic floor muscles.
Timing, how so?
So they can contract quickly and effectively to kind of cinch the urethra closed just before and during that sudden increase in pressure like a cough or a jump. It's about anticipating the stress.
And does it work?
Oh, yes. It's highly effective for many women. It's non-invasive, very few side effects, and the study suggests it leads to a subjective cure, meaning the woman feels cured or significantly better in about 50% of cases.
50% cure rate just from exercises. That's pretty impressive for something non-surgical. What does the actual exercise routine involve? Does it take a lot of time?
It does require commitment. That's true. The standard recommendation is daily practice, usually 3 sessions spread throughout the day.
Okay.
And each session involves doing about 10 maximum contractions. You need to really squeeze as hard as you can, hold that contraction for about 6 to 8 seconds, and then this is important. Fully relax the muscles afterwards.
Sure.
You're building both endurance and power.
So consistency is vital.
Absolutely mandatory for success, really. It's not something you can just do now and then.
Right. Now, what about the other first-line option for SUI, the pessary? Tell us a bit more about that. It's a physical device.
Yes, exactly. A pessary is usually a small device, often made of silicone. They come in various shapes, commonly like a ring or maybe a dish shape. It's inserted into the vagina.
And how does it help?
Its job is basically to provide physical support. It sits in a way that supports the urethra and the bladder neck, the area where the bladder joins the urethra. This extra support helps keep the urethra closed during those moments of increased pressure.
Sort of like an internal scaffold.
That's a good analogy, yes. And in terms of effectiveness, at least one major study found it was pretty much comparable to doing intensive PFMT.
Okay. And you mentioned flexibility.
Yes, a big practical plus is that often the woman can learn to insert and remove it herself. So she might choose to only wear it during specific times, like when she's going for a run or playing tennis, activities she knows might cause leaks.
That sounds really convenient, being able to use it just when needed. If it's that effective and flexible, are there downsides? Why doesn't everyone just use a pessary?
Well, the main challenge seems to be long-term use or adherence. Studies show that about half of women who start using a pessary eventually stop using it long-term.
50% dropout. Why?
The main reasons cited are usually related to comfort or side effects. Things like increased vaginal discharge, sometimes irritation, or even small pressure sores or ulcers in the vaginal wall. Or for some, they just felt it wasn't providing enough benefit to put up with the hassle. So initial results can be good, but sticking with it can be tough for some. Okay, so that covers the main approaches for SUI. Shall we switch gears now and talk about urgency incontinence, UUI? This type often becomes more prevalent as women get older.
Yeah, let's do that. And the approach is totally different here, right? Because it's not about pressure, it's more about the bladder signaling.
Exactly. The problem in UUI is often an overactive bladder muscle, the detrusor muscle, contracting when it shouldn't, leading to that intense urge. So the first-line treatment isn't about brute strength. It's about retraining the system.
So behavioral management first. What's the strategy called?
It's typically called bladder training, or blast training in some sources. The core idea is behavior modification. You work with a patient to gradually increase the time between trips to the bathroom.
How does that work? You just hold it longer.
Not exactly just holding it through sheer willpower. You use a schedule. You start with voiding at set intervals, maybe every hour, whether you feel the urge or not. Then you gradually try to stretch that interval out, maybe to 1 hour and 15 minutes, then 1 hour and a half, and so on.
Okay, but what about when that sudden, overwhelming urge hits between scheduled times? That's the defining feature of UEY, isn't it?
It is. And that's where specific coping techniques come in. When that intense urge strikes unexpectedly, the strategy isn't just to tense up. It's actually to try and distract yourself. Maybe count backwards from 100, focus on your breathing, deep, slow breaths.
Relaxation techniques.
Yes, relaxation and distraction. And importantly, you also use light pelvic floor contractions. Not the strong SUI-type contractions, but gentle, quick flicks or pulses.
Why light contractions?
Because these gentle contractions seem to send a signal back to the bladder muscle, helping to inhibit or suppress that involuntary detrusor contraction. It can help calm the urge enough to make it to the next scheduled void, or at least get to the toilet without leaking.
Interesting. So retraining the bladder-brain connection in a way. What if bladder training alone isn't enough?
If bladder training doesn't provide sufficient relief after a decent trial, then medication is usually the next step.
Okay, what kind of medication?
The first choice drugs are typically from a class called anticholinergics. A common example you might hear about is toltrodine, often in an extended release form.
And how do they work?
They work directly on the bladder muscle. They block certain nerve signals that cause the bladder to contract, basically reducing its hyperactivity and making it less likely to spasm inappropriately.
Do they tend to be effective?
They definitely can be, yes. Many women find significant improvement in urgency and leakage. However, there's a pretty significant catch.
Which is?
Side effects.
Yeah.
Anticholinergic drugs are kind of notorious for them. Things like dry mouth are very common. Also constipation, sometimes blurred vision or headache.
And that affects whether people keep taking them?
Massively. The dropout rates are unfortunately quite high. The sources suggest something like 2/3 of patients stop taking these medications within about 6 months, mostly because the side effects become too bothersome. So it's often a trade-off patients have to weigh up.
Right, the benefit versus the side effects. Okay, so we've covered conservative options for both SUI and UUI. What about surgery? When does that enter the picture? You mentioned a sling earlier.
Yes, surgery is generally considered more for SUI, specifically for severe SUI. So we're talking about women who are having multiple leakage episodes every week, and it's causing them significant distress, really impacting their daily life.
So not usually the first option.
Not typically, no. Usually you'd try PFMT or a pessary first. But in cases of very severe SUI, the guidelines do suggest that placing a midurethral sling, that's the midurethral bangee, can be discussed as an initial option alongside the conservative methods. It really depends on the severity and the patient's own preferences and how much it's bothering them.
Okay. A midurethral sling, how does that work and what's its track record like?
It's usually a small piece of synthetic mesh tape that's placed under the urethra, kind of like a hammock. It provides support right at the midpoint of the urethra, doesn't squeeze it shut, but it provides a backstop, helping it stay closed during pressure increases.
And the results?
The success rates are actually quite high. Around 3 out of 4 women, 75%, report being cured or very significantly improved 1 year after the surgery.
That sounds really effective for those severe cases.
It can be life-changing for the right patient, absolutely. Although it's fair to say the effect might slightly decrease over many years. For some, it's generally considered a very robust procedure.
But as with any surgery, there must be risks involved.
Definitely. It's crucial that women understand the potential complications before deciding. One possibility is developing new urgency symptoms or even UUI after the surgery that happens in about 6% of cases.
So fixing one problem might sometimes trigger another?
It's a possibility, yes. Another risk is difficulty emptying the bladder afterwards, urinary retention. That also occurs in about 6% of women, and sometimes it might even require another procedure to adjust or cut the sling.
Okay.
And then there's the risk of the mesh tape itself causing problems, like erosion, where it might poke through the vaginal wall. That's less common, around 2%, but it's a serious complication when it happens. So it's a decision that needs careful consideration and discussion.
Absolutely. Okay, let's zoom out a bit now. We've talked about types and treatments, but what about other factors that might contribute to UI? It seems like it often doesn't happen in isolation. Are there links to other health conditions?
Oh, absolutely. Comorbidity is a huge factor. One of the strongest links is with obesity. Having a body mass index, or BMI, of 30 or higher significantly increases the risk.
Does losing weight help then?
Yes, very much so. The evidence is quite good here. Weight reduction can have a really positive effect. Some studies suggest that losing a significant amount of weight can potentially cut the number of incontinence episodes in half.
That's a powerful non-medical intervention. What other conditions are linked?
Well, basically anything that chronically increases pressure inside the abdomen. So think about chronic lung conditions like COPD or severe asthma where there's a lot of persistent coughing. That puts constant strain on the pelvic floor.
Makes sense.
And also conditions that affect mobility. Things like severe arthritis or neurological disorders like Parkinson's or MS. If you can't physically get to the toilet quickly when you feel the urge, that can lead to leakage, even if the bladder itself is working okay. It becomes a functional incontinence.
Right. What about lifestyle factors? People often wonder about things like caffeine or smoking. What do the guidelines say there? Let's start with caffeine.
Yeah, caffeine is an interesting one. The data is a little bit mixed or nuanced, maybe. There is an association between high caffeine intake, defined usually as over 200 milligrams a day, which is roughly more than 2 standard cups of coffee, and an increased risk of UI.
Why is that?
Caffeine is a known bladder irritant. It can make the bladder muscle more sensitive and prone to contracting.
So cutting back on coffee should help reduce leakage.
Well, that's where the evidence gets a bit inconsistent. Some studies show reducing caffeine intake doesn't necessarily lead to a significant decrease in the actual frequency of leakage episodes.
Oh, so it might not stop the leaks themselves?
Maybe not always, or not completely. However, where the evidence is pretty consistent is that cutting down on caffeine often does help reduce the symptoms of urgency. That feeling of needing to rush to the toilet might lessen, even if leakage still occurs sometimes.
So it helps manage the sensation more than the physical event itself, potentially? What about smoking?
Smoking is much more clear-cut, unfortunately. It's strongly linked to an increased risk of UI. Heavy smokers, say more than 20 cigarettes a day, seem to have about double the risk compared to non-smokers.
Double the risk. Why such a strong link?
It's probably a combination of things. Nicotine itself can irritate the bladder muscle, similar to caffeine. But perhaps more significantly, chronic heavy smoking often leads to a persistent cough, the classic smoker's cough.
Ah, back to the chronic pressure increase.
Exactly. That chronic coughing puts immense repetitive stress on the pelvic floor over years, weakening the support structures.
Okay, that makes sense. And one last area, could other medications people take for different conditions sometimes cause or worsen UI?
Yes, this is a really important point, especially for older adults who might be on several different medications. Some drugs definitely can contribute,
Which ones should people be aware of?
particularly drugs with strong anticholinergic effects. We mentioned them for treating UUI, but other drugs have these effects as a side effect.
Yeah.
Certain older types of antidepressants called tricyclics, some antipsychotics, even some antihistamines.
And how do they cause problems?
They can sometimes impair the bladder's ability to contract properly to empty fully. This can lead to urinary retention, where urine stays in the bladder, and then you can get paradoxical leakage called overflow incontinence because the bladder is just too full.
Right. Any others?
Diuretics or water pills can obviously increase urine production quickly, which can overwhelm bladder capacity or urgency issues. Opioids can also sometimes affect bladder function. It's always worth reviewing medication lists if UI develops or worsens.
Good point. And just quickly, a special mention for pregnancy and the postpartum period. The situation's a bit different then, isn't it?
Yes, it's quite unique. UI is very common during pregnancy and immediately after childbirth due to hormonal changes and the physical stress on the pelvic floor. But the key difference is the high rate of spontaneous recovery.
It often gets better on its own.
Very often, yes. The data suggests over half, maybe 55% or more, of women who develop UI around childbirth find their symptoms resolve completely within about 6 months without any specific treatment.
So the approach is different.
It often involves more watchful waiting. You might still offer PFMT right away, but often the advice is to wait and see for those first 6 months, given the high chance of it clearing up naturally. Of course, if it persists beyond that, then you'd investigate and treat as usual. So pulling all this together, what are the key takeaways for you, the listener?
Well, first, UI is incredibly common, but far too many women suffer in silence, often thinking it's normal or untreatable. It's not.
And the diagnosis really starts with your story.
Exactly. Your description of when you leak is usually the most important clue to figuring out the type SUI or UUI. Then, the first line of treatment is almost always conservative. Right, pelvic floor muscle training, or maybe a pessary if it's stress incontinence.
And bladder training, focusing on schedules and urge control techniques if it's urgency incontinence. Medication can be a next step for UUI, but watch out for side effects.
And surgery, like the midurethral sling, is really reserved for more severe cases of SUI, and only after you've talked through the real risks and benefits.
Precisely.
You know, the most powerful thing that struck me is just how effective those non-invasive approaches, especially PFMT, can be. They're accessible, they work for many minimal side effects. And yet, as you said, millions of women just assume they have to live with this, that it's untreatable.
It really does raise a bigger question, doesn't it?
It feels like it. It makes you wonder.
Yeah, I mean, imagine the public health impact if we shifted the focus slightly.
Mm.
What if basic pelvic floor awareness and sort of control techniques weren't just taught after problems arise, but were integrated much earlier?
Like preventatively.
Perhaps. Maybe as part of routine health checks for younger women, or even earlier. Just basic education on how these muscles work and how to keep them healthy before things like childbirth or aging start to take a toll. Could we prevent some of this distress from ever developing, or at least lessen its severity?
Empowering women with that proactive knowledge before their quality of life starts to erode. That's definitely a powerful thought to consider. Thank you for joining us for this deep dive.